We do have a powerful panel for you tonight. And to moderate and introduce them, we have Judy Norsigian. She is the executive director of Our Bodies, Ourselves. And she's co-author, of course, of that famous book, now in its 8th edition, last published in May 2005, and is a member of the editorial teams for Our Bodies, Ourselves Menopause, that was published in 2006, Our Bodies, Ourselves Pregnancy and Birth, 2008. Judy speaks and writes frequently on a wide range of women's health concerns, including abortion, contraception, sexually transmissible infections, genetics, reproductive technologies, body image, tobacco, women in health, care reform, midwifery, and midwifery advocacy. She's appeared on numerous national television and radio programs and currently serves as a board member of the Public Responsibility in Medicine Research. Personal recognition include the Public Service Award from the Massachusetts Public Health Association, the Radcliffe College Alumni Association Annual Recognition Award, the 2002 Massachusetts Health Council Award, and an honorary doctorate from Boston University in May 2007. Judy, welcome. Welcome to the panel.
Can I be heard? Great. Wonderful. Well, I bring greetings from all the founders and the board members and the staff at Our Bodies, Ourselves. We used to be called the Boston Women's Health Book Collective. It's still our legal name. And I hear that Julio Frank mentioned us this morning and want to urge all of you to visit our website, ourbodiesourselves.org, to learn about many of the international projects, the women's organizations from around the world who've taken Our Bodies, Ourselves and created translation adaptations, booklets, posters, the most amazing array of projects. The most recent one is a Bangla edition that was produced for women in West Bengal and Bangladesh, and there's an article about that at our website as well. So please use our website as a resource for activists all over the world doing this kind of advocacy that we're going to touch upon today. I am going to actually comment after the speakers and footnote some of what they're saying. I also have brought some materials, as did some of the other speakers, resources, newsletters, information about a fabulous new curriculum called It's All in One Curriculum, some of you may know about, which is a resource for integrating gender issues and human rights into the heart of sex and HIV education. It's a collaboration of numerous global organizations, and it's really a stellar set of volumes, and it's all available on the internet this coming week. Not yet there, but it'll be posted soon. And do avail yourself of these resources. I also want to say that this is an extraordinary opportunity for women in this country and women in other countries to compare notes. We all address environmental factors in our work. We all address MCH, maternal and child health issues, violence issues. And even if we have a smaller focus where we have expertise and we work on in a daily fashion, we all have to be interested in the issues of violence, the environment, and maternal and child health, and broadly speaking. One of the things that I hope we'll do during the question and answer period, and we've left lots of time for that, is that you'll fill out your question cards and pass them to the front. Ann Titleman here is going to be looking them over and making sure that we get to some of the great ideas you've got. And we might even ask some of you to expound upon what you've suggested in your cards. This is a great opportunity for exchange and to learn from one another. Some of our problems are similar, some are different. And of course, though we're going to be focusing on women in the urban environment, it goes without saying that many of these issues really cut across all geographic settings and address women in all settings. So our first speaker is going to be Kirsten Stewart. Kirsten's a UPenn grad, so maybe the only one on the panel. And she first started out as a staffer for a member of Congress, and then she moved on to work for the Family Violence Prevention Fund, which is based in San Francisco. And she's been there for 10 years as an extraordinary advocate. And so she's going to speak for a little while, and then we'll move on to our next speaker.
Thank you again, and thank you, Judy, and thank you to all of you for being here after what I understand has been a spectacular but very, I think, long and intense day. So you honor us by being here tonight, and so we will try to do the same as well in our presentations. I think I was asked to go first because I think I had some success stories to share. And so that's what I really want to do is the first thank you. I think my story is probably like many of you here, which is that I actually, even before coming to Penn, I actually started off as a journalist because I was sure, I went to Northwestern into the Medill School of Journalism, and I was going to speak truth to power because that's what I was about. And then sure enough, I came out and realized the journalism field wasn't quite what I thought it was. The New York Times didn't just grab me up at 22 and say, come run the national edition for us. So I did a brief stint as a journalist, and then I indeed actually went and worked at a Planned Parenthood clinic. I had started doing some volunteer work and just helping them write some publications, and then sure enough came back to grad school to, as many of us do, to sort of sort our paths and to continue our educations. And so my Penn education has helped me in absolutely everything I do. But it's also in many ways what drove me into some of the advocacy work. So that's what I'm going to talk about here today. So my organization, let me tell you just very quickly, is the Family Violence Prevention Fund. We are based in San Francisco. We are a national nonprofit organization. We started, like many violence against women organizations, actually in the late 70s. We got our first grant from the Carter administration and actually incorporated in 1980. And we wanted to get the country to take domestic violence seriously. And we started, like a lot of folks, saying, this is not a private family matter, this is a public issue, this is a crime, and we need to treat it as such. And I think where we came to fairly quickly was, yes, that needs to happen. Yes, we need to bring this issue out of the shadows. Yes, we need to say that behavior that we would never tolerate against a stranger is not behavior we would tolerate against a family member either. But what we also realized is that what most women want, and if our job as advocates is to represent the needs of the people that we supposedly are there to help, then we must first and foremost listen to what they tell us. And the truth is, what many women tell us is that they really don't want him to go to jail, and they don't necessarily want to be involved with the child welfare system. And shelters can be wonderful places, but they're also very hard places to be. And so they would like solutions. Their first request to us is often fix him. I want you to fix him. I don't want to go to shelter, and I really don't want my child to go in the foster care system. I want you to fix him. And, it's always a disappointing reality that in some cases we can't necessarily fix him. We can do our best, and we can also try to support her and support her children. But our organization really started stepping back, and I think part of being based in an urban, very diverse community like San Francisco was the recognition that the criminal justice system is not the best solution for most of the women in our community. We have, again, a very large immigrant community, a very large urban community, and the women that we were advocating for said, we want you to stop it before it starts, and we want you to help the people once they're there. We don't necessarily want to put them in jail. And so our organization really changed its mission to be one focused far more, moving upstream, following that public health model, to look at primary prevention, to some extent secondary prevention as well. And we really have spent a lot of time saying, first, how do we make it a crime, and how do we raise public visibility? And that's what we did. And then we started working with all the systems that women come in contact with, from the child welfare system to the judges. We kept saying, where do you get stuck? As you try to free yourself from violence, where is it that you get stuck? Well, I try to get a divorce, and I can't get a divorce, and the judge doesn't believe me, and, I'm trying to raise these two kids, and I show up in court, and I'm late, and I'm tired, and I've got spit up on my shirt, and, and he strolls in, and he's got his suit, and he's got his attorney, and, I'm losing custody, or I need help with housing, things like that. And so we started working with the TANF, with the welfare system, and with child welfare system, and training the judges. And then really from that work, we started working a lot with healthcare providers. And one of the things we realized, and many of you are nurses and clinicians and researchers and practitioners, that you're the people that women trust, right? And that's the thing that we realized, is that we as domestic violence advocates wanted to, we were too often waiting for women to come to us. And only a very small percentage of women actually ever come to us. But almost every single woman in this country, and as we're starting to learn more and more around the world, sees a healthcare provider. And if they're going to see anybody, they're going to see a healthcare provider. And the nurses are often the people that they trust the most, right? And so what we started to realize is that we need to get the healthcare system involved, both in terms of understanding what the health consequences of violence are, but also to be a place of action, right? Nobody goes into healthcare work because they don't care about improving the health of the women and children and families that they serve. That's why we do this work. But it was still very much a sea change to try to encourage healthcare providers to see their role as it's not just, what is she presenting with and how do I treat it and send her off on her way. One of the things that we often say is you would never send her, if her blood, you take her blood pressure, and if it's skyrocketing, you're not going to send her and say, okay, jot it down, off you go. You're going to say, we need to deal with this right now. And so what we've said is you need to do the same thing about violence because it's affecting her health. But you also have an incredible role as a proactive source of information and trust and comfort for her. And merely by asking the questions, by expressing concern about her health, about her safety, by providing her even the most basic information about how violence could be affecting her health, how violence could be affecting her children's health, you can be a lifeline. And I love to tell one story, and then I'm going to get into some of the more nuts and bolts practical pieces of what I was going to talk about. And it was one of our internal medicine, it was actually a doc, who talks about, what was his light bulb moment. And he says it was a woman who came in with her 3 kids. And she kept apologizing to him for having the kids. She was just there for a regular checkup. And she said, I'm so sorry I needed to bring all my kids with me today. I would never normally do that. And he said, oh, no problem. This is a family practice. And then, at some point during the, he's asking her some questions. She once again reiterates how sorry she is that she had to bring her children. And sure enough, he does the visit. Everything's fine. He's, writing the last order, sends her out the door. And once again, as they're walking out, she says, I'm so sorry. I had to bring all 3 of my children with me today. And he says, he sends her on his way. And then he closes the door and he says, oh, my gosh, what was it that she was trying to tell me? And he opened that door back up. He went out and talked to her. And sure enough, the woman had just found out, honestly, that one of her children was being sexually abused by her partner. And it was only because she didn't come in and say, fix this. And that's not what she was presenting with. But he had the sense to read the signs, and he went in, and he changed the life for that woman and her children from that day forward. And it wasn't because of anything she came in presenting with. And that's where we see the opportunities within the healthcare field. So our organization has a grant from the Department of Health and Human Services to be the National Health Resource Center on domestic violence. I think that's what we're funded to do. I think as many of us understand, we realize that when we have really moved from this idea of domestic violence to a notion of violence across the lifespan. That when we talk about how we want healthcare providers to engage with women and how women experience violence, it's not any neat, tidy little box. It's often at different points in their life with different consequences in their life based on what's going on in their lives. And so we really look about sexual violence. We look at the experiences of child abuse, child sexual abuse, how that may increase risk for teen dating violence, how that then increases risk for HIV/AIDS, STIs, reproductive health outcomes as well. We're finding out a lot more about young people and teens and the incredibly high rates of physical and sexual abuse that they're experiencing, and that it's often getting missed. It's getting missed in schools as bullying or sexual harassment, which is important that we're taking that on more seriously, but we're missing that this is about dating violence. And in the healthcare setting, and I know we're going to talk about some of the healthcare pieces later on, everybody talks about, adolescents don't need, don't require a lot of health care. They're sort of our least expensive group. And what a lot of the folks I talk to say is not that they don't need health care, it's that they're not getting health care. And that's a very different thing. And so what we also are realizing is that teen dating violence, which is some of the stats I think that you see up there, we really want to encourage folks to see teen dating violence and to see how physical and sexual violence and coercion are impacting teens and young people's health, their reproductive health, their rates of HIV/AIDS, and unintended pregnancy. Because it's one of the things where there's, I think, some really good research, and we appreciate many of you in the room for bringing that research to our attention as advocates, because now we've been able to bring forward some laws and policies to address it. I want to touch on 2 of those briefly, one domestically and one internationally. And I figure in a room like this that ideas about that there are opportunities for funding to do the work is also a good thing to share. So based on, again, much of the research of those in this room, the Violence Against Women Act in 2005 included a title for the first time, a health title. And we called it, VAWA Health. And it included all of the things that many of us have told the advocacy community that they need from a very practical standpoint, which is that we need the evidence base to tell us that if you start asking questions about violence and you start actually having interventions to address it, that you're going to then reduce the violence or that it's going to have some impact. So this legislation included research, included evaluation for existing programs. It included the creation of public health partnerships, right? So bringing the healthcare community together with the advocacy community. One of the things we so frequently hear from providers is, I can't spend all day with her. I think all of the pressures on the healthcare world right now are sadly, driving us away from spending time with clients and patients. But what we say is when you create partnerships, and this is one of, I think, the key things about advocacy, you don't have to do it by yourself. And that's, I think, one of the really important lessons. And so by bringing advocates and providers and other folks within the community together, we can meet the needs of those who are experiencing violence. And sure enough, this last year, the first funding, the RFP went out, and in 2 weeks, we're going to have the first meeting of 10 states that have been funded through the Violence Against Women Act Health Program that are going to be providing direct services specifically focused around the intersections of physical and sexual violence and reproductive health, HIV/AIDS, and adolescent health. And so this was an effort of taking the research and taking practitioners who cared about the issue, putting them to work as advocates, and getting some actual results. Legislation got passed, that legislation got funded, and that legislation is now out in that policy is now out in the field. And I hope to be able to come back to you and start telling you that there are some results and some real practice change because of that. And I know we have some of you in the room to thank for that. The other piece that we wanted to talk about, and I know there are, I think, visitors from 35 countries we heard, which is spectacular, is a new initiative called the International Violence Against Women Act. And this was an effort spearheaded by some U.S.-based organizations, again, really trying to listen to what women in the field were saying that they needed from the U.S. government. And I think many of us, particularly we all come from different political persuasions. I think there have always been disagreements about what the role of the U.S. government in the world is. I think there have been concerns that we have been viewed as one of the bullies of the world. And so there was a lot of pushback to say, when we started saying, the U.S. government needs to take a leadership role in ending violence against women and girls around the world, we got a lot of pushback from many of our colleagues saying, butt out, we got it. We don't necessarily like how you're playing in the world, and, we can handle it. And these were often from many of our friends. And so it was good advice. And what we really did as one of the organizations working in partnership with other organizations and leading the effort, is to do what we consider one of the sort of model advocacy approaches, which is that we first found within U.S.-based organizations those that were like-minded but different. We don't need to all do the same thing. We don't need to be experts in the same thing. My organization was a violence against women organization. We partnered with Amnesty International, which was finally, as a human rights organization, taking on the issue of violence against women and women generally as, women's rights are human rights. And we pushed back against our human rights colleagues sometimes for not always necessarily getting some of the women's work. We partnered with an organization called Women Thrive Worldwide, which tries to make trade policy benefit women. And that was really their expertise. And we partnered with Global AIDS Alliance, so one of the leading HIV/AIDS advocacy organizations. And we said, okay, let's bring together our expertise to try to create public policy that benefits women globally. And then we said, okay, well, who are the real experts? So our job is to hold our own government accountable. But what is it that we want our government to do? And that's where we really said we need to go talk to the women who are doing the work on the ground. And I know you heard today, and we all hear in our work, the stories of just these heroic women. And every day I get tired and I feel overwhelmed and I think I'm too busy. And then, I think of one of these grandmas who is trying to run her NGO, is, taking four of her own, her daughters passed away from AIDS. She's got her daughter's 4 kids and the 3 other kids from the community that are now living with her. And she's taking in these orphans and she's running this organization. And as we all know, these women in our communities, she is the center of this community in terms of who's getting water and who's getting food and, what's he doing over there to his niece that's now moved in with them because her parents have died, right? And so we need to draw inspiration from these women, but I would also argue we don't need to make them do it themselves all the time either. And so how do we in our advocacy efforts become informed by the work of women on the ground, honor their heroism and their dedication and their expertise, but then provide them some help? And that's the argument that we would make, which is that the U.S. government does have a role. and that U.S. leadership does matter, but it has to be informed and done in partnership with women on the ground. And that's what the International Violence Against Women Act does. It's not about funding necessarily U.S.-based contractors, but it is about how do we get direct resources to women's organizations on the ground. And we require it flat out that local women's groups have to get funding themselves to implement the solutions that they think are most appropriate, which may not necessarily be the solutions I think are most appropriate. This legislation, I'm happy to say, was co-sponsored, first introduced by Senator Joseph Biden, now Vice President Biden, co-sponsored by Senators Barack Obama and Hillary Clinton, now our Secretary of State. You heard Ambassador Verveer this morning, obviously our Secretary of State and our President. It was reintroduced about a month ago by Senators Kerry and Boxer and Snowe and Collins from Maine. So it's a bipartisan bill in the House and the Senate, and there's going to be a hearing on it. Been 2 hearings already, and we expect another hearing and markup next week. So there are some really wonderful actions that are happening, some policy that is taking place. And I will just conclude with the idea of, I always feel like I have to sell the idea of advocacy. I think it's very appealing to all of us to want to go out there and do direct services. I want to do what I know how to do, and I want to do it well. And what I'm going to ask everybody in the room to do is just find another 5 to 10 minutes and get involved in doing advocacy. Every person in this room is able to do advocacy. There is no job you have, no title you have that ever prevents you from petitioning your government with your ideas and your grievances, and you are experts, and you should embrace that. And they have every right to hear from you, and I would argue you have a responsibility to bring the voices of those you care about, to bring your own knowledge and expertise to the public forum, to public officials, to news media, to whomever it is, because advocacy does work. And you are the experts, and you all can be advocates however you want to do that. So I encourage you to embrace that and also continue the great work that you're doing.
Thanks so much, Kirsten. That was really terrific. And I'm going to make a few footnote comments, partly because I know some of you want to think about how to get out there and plug in and share your experiences and work with other advocates. I want to mention that there are some efforts that have brought teenagers together to look at this issue as advocates for themselves and their peers. Teen Voices magazine, which is based in Boston, but it's national, is a fabulous organization teaching young women editorial and writing skills, but it turns out, not surprisingly, that a major focus in terms of content in their magazine has been the question of violence, dating violence. And if any of you want sample copies, just give me your card, and I'm happy to have them sent to you. It's a fabulous organization. I also want to tip my hat to the men in the world, not just in this country, who have taken on the question of violence as advocates, particularly violence prevention, so that we see many men's initiatives. The Men's Initiative at Jane Doe Inc. in Massachusetts, which is our statewide coalition of about 60 organizations that work on domestic violence and sexual assault. And it's very interesting that many of these organizations used to use the term violence against women in their title, but now they recognize that even though the majority of violence is male violence perpetrated against women and some other men, that it's often more helpful to talk about the behaviors and talk about the ways in which everybody can participate in changing the atmosphere which produces a culture of violence. So the men who have taken up the White Ribbon Campaign, who have taken up working with the local Ys, who've taken up working with sons and fathers, they are to be credited. I urge you to think about plugging into your own White Ribbon Campaign. Most cities have one. We're not like other countries where it's all around Thanksgiving Day, because the United States couldn't do something like that. But we have them in Valentine's Day and other parts of the year. And one of the things that's most impressed me is that some of the famous sports stars, we got Leon Poe as a starter for the Boston Celtics to come out and be part of our White Ribbon Day campaign a few years ago. They're willing to be out there and help role model and to take the pledge, which is about 2 sentences long, but it really is about saying, I'm going to be an advocate for change. And I also want to give you a reference that is a very new book, and for me, a sea change in terms of what's out there, synthesizing the advocacy work and the research. And it's a book by James Potacek, who is a professor at Suffolk University. He's a sociologist with expertise in the criminal justice system, but his book is called Restorative Justice and Violence Against Women. And in it, you'll see chapters by women who never thought that a restorative justice approach, much like we saw in South Africa, could work in the context of violence. But actually, there are many settings in which they've done research, and it has worked. So for those of you looking for innovative ways to get at this issue and to advocate for another approach, do look up James Potacek's book. And then one other little kind of alphabet soup issue for those of you from other countries. When we use any sort of language like that, call us on it. TANF stands for Temporary Assistance to Needy Families, but we call it TANF in this country. And it has a lot of problems, but it also is a source of resources for some individuals. So I'll stop with my footnoting there, and I'm going to move on now to Giovanna Di Chiro, who is an environmental scientist, and also an activist, a community activist, and someone who's been a scholar in the field of environmental justice. And she works at the intersection of the environment and social justice movements. And this is a huge arena and it certainly takes a lot of our attention. And I think it's one of the places we're seeing really wonderful movement that's looking at racial disparities and community building involving people on the ground in the community and activists and academics who often have the know-how and the research skills. So Giovanna did actually teach for a while at Mount Holyoke, and my daughter had the wonderful fortune of learning from Giovanna and used to tell me all the wonderful things she learned from you. You don't know that, but...
And your niece, too.
Yes, a niece as well. So not just those. There were others who took courses with you, but I won't tell you the list of young women who really felt you were a wonderful role model for them, and I think they're turning into activists in their own rights. Anyway, Giovanna.
Thank you. Thank you so much to Judy and to Anne and to Caroline for bringing us here, and thank you to all of you for coming here at this hour. I'm glad I had that chocolate cake because it's giving me some energy and some caffeine to keep going. So as Judy said, I want to talk tonight about or drawing on my dual roles as a community activist. At the current moment, I am the director of environmental justice programs at a community organization, community development organization, and environmental justice organization called Nuestras Raíces, which means our roots in Spanish, and it's in Western Massachusetts, in Holyoke, Massachusetts. And also as a scholar of environmental justice who has studied the organizing strategies and work of women activists around the world for many years. My work, as Judy mentioned, with her wonderful daughter, Kiro, was one of my students in one of my courses called Urban Ecology, which is a community-based learning course. I introduced a lot of community-based learning in my courses. And I taught in environmental studies, in women's and gender studies, in science and technology studies, in history of consciousness. So many of the departments I've taught in different institutions have been very interdisciplinary. And I have tried to introduce this notion of how we can blend an academic and an activist and an advocacy-oriented form of education and research. And I will say that despite the fact that I have done it my entire career, it's not easy. And it's actually not easy being an advocate and, trying to be involved in these different spheres. In many ways, because our institutions do, in fact, try to split them. And it's difficult for someone whose work is primarily within a university or in the academy to actually try to bridge those spheres. And so I will sort of say that in the process of my community-based research or community-based learning and also research with my students and with partners in the local communities that I've lived in, one of our partners was the EPA. And the EPA has recently started, actually within the last 5 years, a really interesting program called CARE, Community Action for a Renewed Environment. And I'm sorry, the Environmental Protection Agency in the United States. So the Environmental Protection Agency has, which is a federal agency, which started this program called CARE, Community Action for a Renewed Environment. And that is an attempt to provide resources, technical resources, funding to communities, environmental justice communities, communities of low-income people, largely communities of color in the United States who are suffering from some of the most serious environmental hazards. People who live, whose neighborhoods and whose local communities are situated near incinerators or toxic waste dumps or other hazardous facilities, and they suffer the health consequences as a result of being exposed. So this money has been being funneled towards communities, and using my scientific skills of research and grant writing, actually wrote one of these grants with Muestras Raíces in Holyoke. And so now I've sort of shifted from a more academic locale to an activist locale, and that's how I see myself now. But I have to say, I kind of had to shift to do that. It's difficult to do one and the other. But so the point that I really want to make tonight, and as an academic, I have my little notes here, my little talk that's supposed to span the 15 minutes that we were given. But the main point that I want to make is that women grassroots activists in the environmental justice movement, both in the United States and internationally, do not address health issues as separate from other problems in their communities. So they see the connections between rising rates of chronic diseases such as cancer and asthma and obesity and diabetes. They see the connections between those and high unemployment rates and deteriorating inner cities with little access to clean and safe green spaces, and also the rising rates of urban air sheds that are consistently out of compliance with the EPA's federal air quality standards. And that includes many cities, including many parts of Philadelphia. So women activists who I've been working with and interviewing and writing about see the national epidemics that we're seeing in U.S. cities of obesity and asthma, the shortage of good jobs and healthy workplaces, and the high levels of air pollution, including excess concentrations of carbon dioxide and other greenhouse gases that are contributing to global warming. They see these problems, which are disproportionately affecting communities of color and poor communities, as interlocking problems that require interlocking solutions as well. And one of the things that with my community-based research, with my students, with the community partners that I've worked with over the years, is I see that women activists actually blend or create a hybrid form of environmental knowledge, a hybrid form of environmental expertise by recruiting and mobilizing diverse partners, including people like myself, with the scientific expertise. And I call this blended, hybridized knowledge, I call it uncommon expertise. And I see that sort of expression of uncommon expertise that blends locally based experiential knowledge about the effects of environmental deterioration in our communities with the more academic and scientifically based knowledge about ecological destruction. I see that as the most potent form of knowledge to solve problems. And I saw an expression of this notion of uncommon expertise recently when I was invited to a recent White House summit for community stakeholders, for environmental justice communities. And it was hosted by Kathleen Sebelius, who is the Secretary of the Department of Health and Human Services, and Lisa Jackson, who is the Administrator of the Environmental Protection Agency. And the topic of the summit was about how to bring community activists together with federal representatives, particularly Health and Human Services and the EPA, how to bring them together to talk about the interconnections, in other words, this uncommon expertise between health, public health, environmental quality, and economic development. So it was the first time that these two agencies had actually come together to start bridging these divides that usually separate public health from environment, from economic issues. And the thing the reason for bringing them together, this was in late October, was the hope was that the Obama administration would get the health care policy off the table, which it didn't at that point, but the intention was to bring together these community stakeholders across the United States to start talking about how we start thinking about climate change policy and energy reform. And so the question of linking public health, environmental issues such as climate change and how climate change is going to start affecting local communities, and economic development. So one of the things that brings these issues together is trying to think about what kinds of economic development, what kinds of jobs can we put into place that will actually address the need for employment in marginalized communities in the United States, while at the same time addressing the issue of climate mitigation. And so the hope was to bridge the divide between discussions about sustainability, environmental sustainability, and social justice. And these are two areas that have very rarely been talked about in the same terms. So what I want to do is just talk about two examples of community activists, largely spearheaded by women activists in the U.S., who are addressing issues of local sustainability, economic development, and economic security, and also the broader issues of global climate change. So in many ways, the environmental justice movements that I've been involved with, including with my own organization, are doing what geographers call jumping scales. That they move from the local environment, the local community, the grassroots issues, to something as broad as global change, global climate change policy. This is something that the federal government in this summit was trying to address, is how we make those linkages. So one of the organizations that I've worked with in the past that brings together these separate issues in this sort of mixing that I'm calling uncommon expertise is an organization called Asian Communities for Reproductive Justice, and it's located in Oakland, California. And the way that the women activists in this organization talk about this notion of bridging or this intersectional analysis across social justice issues and environmental issues and economic issues is that they talk about looking both ways through the dual lenses of environmental sustainability and reproductive justice. And they do it in order to create, I would say, creative, innovative, and proactive strategies that at the same time mitigate climate change, in other words, reduce levels of greenhouse gases in the atmosphere, and also address the reproductive rights and the reproductive health needs of the predominantly low-income Asian American and Asian and Pacific Island residents of the city of East Oakland. So one of the ways that this group looks both ways, so to speak, is to examine the mid-level industries, such as electronics manufacturing and nail salons, both of which employ large amounts of Asian American and Asian immigrant women. And these are industries, electronics, semiconductor industries, and nail salons that aren't typically the targets of climate change mitigation policies. Usually it's the oil production and gas production industries or the transportation sector. But in fact, they do produce a significant amount of greenhouse gas emissions in their production processes and also in the chemical feedstocks that are used in their products. And at the same time that they produce a lot of greenhouse gases that contribute to global climate change, the chemicals that are used are also known to put the health of the largely women workers at risk. So the women leaders of this organization, Asian Communities for Reproductive Justice, and they include the executive director, Evelyn Shen, and Aparna Shah, they've documented how women working in the microelectronics and nail salon industries are exposed to industrial chemicals such as perfluorocarbons compounds, or PFCs, and the so-called toxic trio, dibutyl phthalates and toluene and formaldehyde, which are classified by the Environmental Protection Agency as potent carcinogens and reproductive toxins, and they're also classified as potent greenhouse gases, which contribute to global warming. So by looking both ways, the organization has built coalitions across environmental organizations, women's rights organizations, labor organizations, to advocate on the one hand for workplace health and safety issues in the electronics and semiconductor industries, and also for climate change solutions that are linked to social justice. So last year, just in terms of a success, they actually convinced the California legislature to adopt regulations to phase out several harmful chemicals that are used in the microchip. In just 1 minute, oh my God. Okay, so I'm going to move on to the organization that I work with then, Nuestras Raíces, and I just want to say in 1 minute, okay, see that's why I have to stick to my script here, because then I can get it all in. Okay, so one of the things that Asian Communities for Reproductive Justice does too is they have organized a women's union, a women's advocacy union around salon workers called Polish. And these women workers, most of the, 80% in fact, of the nail salons in the United States are staffed and owned by Asian American women, particularly Vietnamese women. And so that this women's union has created multilingual educational materials to actually educate women workers and also consumers about the problems of the toxic chemicals used in nail salons that are also greenhouse gases. And in terms of policy change, in terms of that jumping scale, the California has started to institute a safer alternatives bill. But anyway, I'm going to move on quickly to Nuestras Raíces and just say a few things about this urban environment. This organization primarily serves the Puerto Rican and Latino residents of Holyoke, Massachusetts. The population of Holyoke, Massachusetts, which is about 40,000 people, is about 41% Puerto Rican and Latino. Puerto Rican residents migrated from Puerto Rico primarily in the post-war period to work in the agricultural fields, and then set up residents in the abandoned tenements that had once housed European mill workers in the industrial town of Holyoke. But as a result of the deindustrialization of Holyoke in the early 19th century, the city has become a blighted inner city area or urban area with hundreds of contaminated brownfields and abandoned factories. But the Puerto Rican residents, including largely women activists, my colleagues, Julia Rivera, Maria Salgado, Milagros Guzman, have transformed this urban blight into what they call landscapes of hope. And they talk about being protectores de la tierra, or protectors of the earth, but also transforming this urban environment, which really is a post-industrial landscape with all of the toxic and chemical problems resulting from deindustrialization. But by building a urban foods infrastructure with community gardens and urban farms that actually produce and create access to healthy organic produce in the community. And one of the important reasons for that is because Holyoke has the school children in Holyoke have about 45% obesity rate, as well as in most of the inner city schools. They have an asthma prevalence rate of between 25 and 45%. And there has been research now to demonstrate a connection between exposure to air pollution and obesity rates as well. So the linking of public health problems such as high levels of diesel particulate matter and other industrial toxins, high obesity rates, high asthma rates, high unemployment, and the so-called food deserts, or the communities in inner city areas that have more liquor stores and fast food stores than actually grocery stores that sell fresh produce. So this community urban agricultural infrastructure has succeeded in providing affordable, healthy produce in this community, and we're actually seeing change. And then one final thing, addressing the other aspect of this intersectional analysis is jobs and green jobs, which Kathleen Sebelius and Lisa Jackson were trying to promote in order to address economic problems, in order to address climate change. We just actually launched, just last week, a new company, a new energy services company called Energia, and Energia means energy in Spanish. And this is a new for-profit company that is owned by 3 nonprofits, including Nuestras Raíces. And this is a new model for nonprofits, is to actually go into the earned income model strategy, to actually create businesses that will earn income for the community, but also for the organizations themselves, so that they can fund some of the programs, educational programs and other kinds of programs that we're involved in. So Energia is we just actually launched it last week. We're already in business, and our CEO, who we hired to run the business, has hired 4 of our Green Jobs trainees who are local youth from Holyoke, who now see themselves, and it was the most wonderful experience to actually hear them on the local TV show, to talk about themselves as being part of this new green revolution. And this notion of being part of a green revolution for local Puerto Rican youth who, before being involved in the Green Jobs training program, were in jail for the most part, including these 4 who were recently hired, is a new connection that's being made as a result of environmental justice activism that's bringing these ideas together. Sorry for going over.
That's okay, Giovanna. Thank you so much. And I think it really is important to think about strategies like income generation for nonprofits through these for-profit models, because they can bring about change, and they're good examples of advocating. And there are so many examples from other countries and other cities that I'm tempted to start getting into. I won't. I do want to say that the other examples of collaboration include the Safe Cosmetics campaign. If you go to safecosmetics.org, you will see the linking of a very extensive database with all the products, personal care products and cosmetics, by brand name. And you can plug in your brand name cosmetic of choice and find out what kind of potentially harmful products are in it, and then be given an alternative that does the same thing but without those potentially harmful products. So this is a very practical way, and there's some handouts here that talk about how to make your house safer. The Massachusetts Breast Cancer Coalition, Breast Cancer Action in San Francisco are very, very concerned about the role of the environment, particularly on breast cancer. And as you know, probably, we use a minuscule fraction, like less than 1% of all of our research monies going into looking at environmental questions. And this is going to be something that hopefully will change as some of the smaller breast cancer advocacy groups get more visible and bring the question of the environment front and center. Many of us like to teach and advocate with films because people don't like to read. And I have some cards for a wonderful new documentary called No Family History, which looks at the question of the environment and breast cancer through the lived experience of a woman in New York who had breast cancer. It's a wonderful documentary, about 40 minutes long. There are examples of advocacy work like this, using documentaries. I mentioned over dinner, there's a new one called Made in India, produced by young filmmakers concerned about reproductive tourism and how it's playing out, particularly in India, the country from which one of these filmmakers comes. So I'll stop there so that we can move on to our third panelist. And Jennie Joseph is someone I've known for a number of years. She's a UK-trained midwife, came to this country several decades ago and has been working in the Orlando, Florida area. And not just working there. She's known nationally and internationally as one of the most articulate, passionate, and effective advocates for the midwifery model of care. And if you see Jennie's work, you see the outcomes of what she's produced in her own setting, but also how she's helped and collaborated with folks elsewhere is simply remarkable. So Jennie's going to talk a little bit about her work, and then we're going to open it up with your questions and comments.
Thank you so much, Judy, and thank you very much for being here, and I appreciate the opportunity to speak. I really have very little to say because I think you all know and understand where I'm coming from in terms of you are who you are in your profession, in your field. I'm a midwife, and I've always been a midwife, actually. I started when I was 19, and so I'm heading into 30 years of midwifery. And all I know is that women want a midwife. Women who have the opportunity to have a midwife love that experience, will never change it after they've had it. But those that don't know, those are the women that break my heart. When I got off that plane in 1989 and I landed in Orlando, and in Miami actually, but I've been in Orlando ever since, I didn't know any different. I thought I'd get off the plane, get a job, go catch some babies, do what I've been doing in England, happily go on about my merry way. And I had a very rude awakening. And I'm still recovering. It's been 20 years, but I'm still working on it, because what really is hard for me to grasp is that this is not a normal way to deliver a baby in the United States of America. Those of you, are any midwives in the house? Yay! Midwives, go midwives. Worldwide, the midwife is the guardian of normal birth. The word means with woman. And to me, that's all you have to say. And so it's something that's hard to accept, that it's not standard care for American women. And it's very deep and it's very political. Historically, I've been quite overwhelmed with just understanding the history of midwifery in this country. We've had midwives. Midwives came with the slave women, and they served women for centuries until midwifery became a model that changed into medical hands. But what's particularly hard for me, especially as a black midwife, a woman of color, and working in an urban setting in the Orlando area, is that black women, Hispanic women, American Indian women, Pacific Islanders, women of color disproportionately were having worse outcomes than Caucasian women. And I got stuck right there, because the baby comes out of the, you know what, the same way. And there shouldn't be any difference between outcomes. I couldn't figure out where did that come from. There's classism involved, yes, because poor women worldwide have issues, of course, with reproductive health. But why on earth would it be that in this country, a developed country, the cutting-edge leading country in many medical disciplines, why would it be then that there's such a disparity between birth weight, gestational age, infant mortality? And now we're even talking about maternal mortality, which just blows me away. I have yet to answer those questions, but that's what drives me. So I set up a little teeny tiny practice in Orlando, because once I was turned away from the hospitals, I was laughed out of the hospitals, just let me put it that way, and I really felt very discouraged, but I decided to start a home birth practice because there was some autonomy there for me. And, you know, internationally, midwives are still fighting for autonomy, but at least we exist in many other countries as the main provider of health care for women. But in my little world, I couldn't get my foot in the door, so I decided to open a home birth practice. But then I noticed that the women that were coming were only women that were of means, women that had insurance, women that had education and support, basically white middle-class women. And I enjoyed it. I'd never done home birth to that level before, and I had a great time, learned many skills, because now all of a sudden I was delivering babies in somebody's bedroom. And I didn't have a button to ring and nurses to come running and save the day. I had to build skills that have become very valuable for me in providing care that I now provide for urban women. But in my transition to trying to serve more of a disparate population, to serve more of a minority population, I had to rethink my midwifery. And I didn't know I was an advocate, or it was even an activist, until I had to do that. And what I came up with, and this is something that may work for other areas, and I really want to encourage people to be more open in their thinking about using midwives and the midwives model of care. What I came up with was, you know what? At the end of the day, Does it really matter where you have the baby, so long as you have what I call a big, fat, chunky one? A safe birth and a safe outcome, what building? Does it really matter? And so I let go. I had to be it. I got off my ego trip about I was the one who could best get that baby over the intact perineum and hand it over to the mother. I got over myself. And I realized that at the end of the day, whoever or however the baby is delivered is not that relevant if you can get a full-term baby out of every woman. If you can have the healthy birth weight, if you can have a mother prepared and ready to breastfeed, if you can have a father standing right there with his ability to be right hands-on on his child, first touch, and if you could have that family bonded unit go forward in good health. Because the one thing that I do know that across the board, every woman wants a healthy baby, and every woman deserves one. And I realized in letting go of the birth piece, I could provide the prenatal care and not have the resistance that I'd been experiencing as I was talked about home birth and birth center birth and out-of-hospital experiences. As soon as I started talking along that vein, people shut down. Oh, no, we don't do that. Oh, no. And there was a resistance to the idea that midwives had any part to play in healthcare in this country. And so letting go of the birth opened up the door. Suddenly there wasn't a competition anymore. There wasn't any drama about, well, what was going to happen at the time of labor. Pregnancy and childbearing is not just about labor. The entire prenatal course is one of the most key components because that's where the learning takes place. That's where the empowerment takes place. That's where the bonding takes place. If we leave the prenatal piece out of the picture and fight over the delivery, we're missing out on most of the action. Because if you're looking at the delivery only, you could be delivering a 26-week child. You could be delivering a 32-week child. Whereas if you look at the prenatal and the goal being that full term is the only choice, that's what you get. So I'm not a scientist. I'm not even a nurse midwife. I'm a direct entry midwife. I was trained in a hospital in 1979. But what I do know is that when you treat a woman with respect, when you educate a woman at her level, when you involve her partner and her family and her neighbor and her girlfriend, when you bring the community into your environment and say, look here, we have a job to do. We have one thing to achieve here, a full-term healthy baby. Everybody gets on board with that. And whoosh, it changes. We did a study at our center. I have a freestanding birth center in the Orlando area. We studied 100 of the women enrolled in the indigent outreach practice. I'm not talking about the bona fide birth center women, the women that were healthy and sensible and prepared. I'm talking about women who showed up because they had nowhere else to go, and they heard that the midwives would see them. Out of those 100 women enrolled prospectively in our study, of the 86 women that delivered, 4 low birth weight babies. Not one black baby, not one Hispanic baby. We had 4 babies that were less than 5.8, but higher than 5 pounds. 4. What am I doing? Midwifery care. How hard is midwifery care? It's very simple. Midwifery care is cheap. Midwifery care is effective. It's easy. I have a midwifery school. I'm training direct entry midwives. Why? Because they come from an entry-level perspective. They're open and ready to learn. They were doulas. They were WIC peer breastfeeding counselors. They were women who just helped their neighbors. But they want to serve. And in Florida, with a license, you can provide prenatal care, you can do deliveries, and you can do postpartum care under the auspices of the state of Florida. So we're training women who are diverse women who are going to serve their community, who are right there to help women, at least in the prenatal care, if not in the whole package. But in terms of bringing activists to the table, giving them an opportunity to serve in a cost-effective way, if you can turn the outcomes around with simple midwifery care, my question is then what else should we be doing? So I'm going to stop right there and just hope that you guys have some questions, and I'd be happy to answer how we got this achieved. Looking at this as a model globally, I really see the importance of bringing in lay health workers, bringing in traditional birth attendants, bringing in women who are already doing what we do inherently as women, which is being with women and turning around these horrendous reproductive systems that we have that are creating such pain and horrible statistics that we are experiencing worldwide.
Thank you so much, Jenny. And I will say something about our midwifery advocacy in the state of Massachusetts. We are known to be one of the medical meccas in the United States. And ironically, we are one of 6 states left in the United States that by statute requires the direct supervision of physicians over certified nurse midwives in the hospital setting. Now, actually, a lot of physicians don't like this because of liability issues. But we have been working a very long time to change this law. Actually, my organization didn't get involved in a major way till this past year. I think this year we're going to change it. We have a new bill, and it's a bill that not only eliminates that statutory language so that nurse midwives practice collaboratively with physicians as they do everywhere else in all except 5 other states. We also will be licensing and regulating certified professional midwives, CPMs, who are really the only ones left trained to do births in a home setting. And only a small number of women in the United States choose home birth. That may change over time, but it's never been much more than about 1%. I think the important thing is that we maintain a safe and supportive and respectful environment wherever a woman wants to choose to give birth, she and her partners. And it's so interesting because we have so much data now. The evidence has been in for a long time, and in the last year and a half, we have 4 major new studies. It's such powerful evidence that even the American College of Obstetricians and Gynecologists has to revisit its knee-jerk policy against home birth because it doesn't fly in the face of the evidence now. But one of the things I have to mention about all our advocacy work during the healthcare reform effort these past couple of years, and even if you're not in the United States, you know that we've been working very hard and that President Obama worked very hard, and there were some incredibly difficult political struggles. The 3 big ones that we worked on hard, and many cities had coalitions and many statewide coalitions. We wanted to get something called a public option so there'd be real competition. We could bring down the cost of healthcare because without bringing down the cost, we're not going to be able to really have a system that will survive. The second is to cover all immigrants. This was one of the second things we lost in this struggle. The coverage for immigrants is pathetic in the new healthcare reform bill, but we're going to all work to change that over the next few years. And the third was a setback in reproductive rights. Actually, many of us thought we might take a step forward. But it's not as huge a setback as the Catholic Church would have you think. It's an encumbrance, it's a setback, but it was what we would call a compromise that had to be made in the interests of getting our foot in the door to develop the case for universal access, universal health care for all, because that's never been a principle that's been espoused by the federal government. That's historic in and of itself. But what we got was health insurance reform. We didn't get health care reform, and so we all have to remember that. But in this bill, there is a special clause that says that Medicaid, which funds many of our agencies that serve low-income women, has to reimburse freestanding birth centers. And this comes on the heels of some incredible struggles at the state levels I won't get into right now, where mostly physician-directed forces were trying to block the reimbursement fee for freestanding birth centers. Now, this isn't even home birth. These are birth centers, well-studied, and mostly staffed by certified nurse midwives. So that is one little gem in this bill that I think, though we lost a lot, that's something we gained. There's also another gem, and that is it's a requirement that any employer with, I think, 30 employees or more has to provide a breastfeeding-friendly workplace, a place a woman can express her milk, store her milk, have privacy, and not be told to go to the bathroom to do it. And I think that, President Obama and his wife, Michelle Obama, are to be credited with beginning to be more out there in terms of advocating for breastfeeding as a healthy option and one that at least society should support. So these kinds of small steps in the larger bill, I think, are reflective of our success. In Massachusetts, we put together a 14-minute DVD, totally volunteer labor, the video editor, the camera people, because this is how much people love midwives. A midwife does not speak on this DVD, only physicians and consumers, and a public health expert from the Boston University School of Public Health, a man named Dr. Eugene DeClercq. And I have some copies here. If any of you want to take a look at it, it will be on YouTube within the next few weeks. And we are seeing this as our advocacy tool to make the case for the midwifery model to legislators who are very busy and usually don't have time to think about these issues. So as a model for how you distill a lot of information and get it into a visual format for a staffer or a legislator to look at, I think it's a good example. And you can do this with all kinds of issues. For me, this struggle around midwifery advocacy, which is in our country major at the moment, is going to be a very telling example of whether or not we're going to be able to make progress. The cities that have access to midwifery care for low-income women actually find outcomes for those low-income women to be better than the outcomes for the richer middle-class women who are going to some of the fancy hospitals and have the 50-60% cesarean section rates now. This is one of the best-kept secrets in this country. And I can tell you stories afterwards about hospitals I visited myself and where physicians and midwives work as a team and where midwives do most of the deliveries. And these are women socioeconomically at risk. I can point to a place that uses a freestanding birth center model, the DC Developing Families Center, which was founded by Ruth Lubick, a nurse midwife now in her 80s, who used her MacArthur Genius Award money to start this center in one of the highest crime-ridden rates in Washington, D.C., and she is keeping incredible statistics presented to the Institute of Medicine. I can send you her 2-page paper. She has been featured on television. These things happen in this country, but we are working to get them translated into policy that will enable all women to have access to these options, not just a few women. So it's happening, but you don't generally see it on the news as much as we'd like. So I'm going to begin with a question to Giovanna. And this is from Joanne Hall, University of Tennessee, and I'm really glad that you raised this because I just read an article about this issue. What do you recommend when EPA, our Environmental Protection Agency, has organized efforts like CARE, but for example does not call coal fly ash toxic waste? In Kingston, Tennessee, an Appalachian community, tons of sludge containing radioactive elements and heavy metals went suddenly into the homes and rivers of the area. But because it is TVA, Tennessee Valley Authority, responsible, EPA let it slide, and I can't read that, passed it on. The politics are not simple. There is one standard for the Northeast and another for the Southeast. There is no such thing as clean coal technology. The Tennessee coal fly ash disaster is far greater than the Exxon Valley disaster affecting the Emory and Tennessee rivers and covering a whole community of poor Appalachians, black and white. Few lives were lost, no headlines sustained. The damage will come in the form of future cancers and birth defects. This is truly a post-industrial landscape. As we reel in the wake of the West Virginia mine explosion, we must also consider the newest method of coal extraction, mountaintop removal. This is perhaps the most abominable and will be the most visible symbol of environmental disaster and loss of beauty. I think this is well put. Giovanna, do you want to respond?
So the question, where are, oh, there you are, yes. Well, I mean, I completely agree with you. Now, I think that the EPA is contradictory in many ways. Do I think the new EPA, headed by Lisa Jackson, will move in a different direction? Yes, I do. For example, I mean, the points that you raise also fly in the face of broad climate change policy, too, to be focused on so-called clean coal when there is no such thing. One of the largest producers of greenhouse gases is coal, and coal burning, and coal plants. You're absolutely right. The EPA, including under Lisa Jackson, has not said a lot about either mountaintop removal or the situation in Tennessee, or even shifting to renewable energy sources. However, I've collaborated with Lisa Jackson since she's gotten into office with many environmental justice organizations, and a shift is starting to happen. I do. I mean, I want to sound positive, but I can also be cynical too, because the CARE program is contradictory. CARE means Community Action for a Renewed Environment. And while it does say, the federal government is going to support communities to start doing research about what some of the hazards are that they face in their around environmental health problems in their own communities, so the EPA will help people to advocate on their own behalf, to go to a company and get the technical knowledge to start challenging that company, to get local government to develop local policies. But at the same time, it's a shift of responsibility from for public health from the federal government to the community. And that's kind of a federal devolution process, I think, that we see happening, a shift of responsibility, an abdication of responsibility in many ways for environmental monitoring. So the EPA in some ways says, okay, communities, we'll help you to do your own monitoring, to do your own, pushing local companies and local governments and local health departments to do what they're supposed to be doing. But we'll step back and say we're going to let civil society participate in this. So on the one hand, it's focusing on the community, empowering communities with knowledge to address these issues on their own. And then it's also federal abdication of responsibility for environmental protection. So it's contradictory. I mean, I think this also brings up another issue, and that is, where's the political power? And I think this is an urban-rural phenomenon we see a lot of the time, where if a group of urban activists get together, and there's a lot more of them because there's more of a concentration of people in urban areas, and they have more politically powerful legislators, they can get agencies that may be mandated to do certain things, to do what they're supposed to do because somebody is rattling the cage or somebody has a louder voice. And I think there are many examples where poor rural communities simply don't get counted, don't get heard, even though they try to be advocates, much like urban advocates try. But you sometimes see less success because there is less political power, and it does boil down to that sometimes. This is why the urban areas have to see that what happens in these rural areas actually has an impact. Absolutely, absolutely. And in fact, you may have seen that there are some fabulous strategies that cross these scales, cross the urban and rural scale. And one of them is this great map, an interactive map, and I'm trying to remember the name of the organization that has produced it, but where you can click on your zip code, I believe, or you can type in your zip code, and then up pops one of the mountains in West Virginia that has been decimated by mountaintop removal, coal mining, and the community, and some voices from the community. So of the people who live there, whose lives have been destroyed, and some of the activists who are working to protect the health of the mountains and the people. And so it's a way of having someone in an urban environment connect to this rural place where resources are extracted and mined and people's lives are affected. And the idea is that if you see a face, if you hear a voice, if you see the environment and you know that that's the effect or that's one of the consequences of you being able to turn your light switch on to have electricity, then you start building those connections. Yeah.
This is a question from Dean Melise, and it's to any member of the panel. What advice would you give to those who are responsible for urban development and for those who are developing healthcare systems? You actually began to talk about this a little, Kirsten.
Get organized. I think is it more sort of in the U.S. based or more in the developing world? Which I think is maybe where the question is going, if we're talking about
urban development happens everywhere, and I don't know that there's any intention to think industrialized, less industrialized country. I'm
actually almost, thinking about what you're saying, which is it's about rethinking what people actually need. I think this issue of, San Francisco went through a similar thinking around healthcare issues, which is that everything became about healthcare insurance reform and nothing about actually how do you get people healthcare. And once we started actually talking to people about what they wanted and what they needed in terms of healthcare, and when you think about urban environments, I look at Portland, Oregon, which has been, I just think, so thoughtful in terms of urban design and how do you actually connect people to the services that they need and want, and how do you help them create the services that they actually want in their own communities and bring in the people that they want in their own communities. So, that to me is, as always, it's about figuring out first what people want, where they want it. The building, in most cases, doesn't matter. Obviously, technology and, technology can be good and bad, right? But then there are also obviously enormous opportunities with technology that don't actually require transportation. So from an environmental perspective, that's also critically important. I'm not sure that got the answer, so I'd be interested in
Anybody else want to add to that?
I just wanted to say that I think that the main aspect for urban women is access, which you think would be a rural issue. Like, oh, you can't get there, it's so far away. But with the access piece, what I really mean is that wherever and however you can provide the service, that the practitioners of that service are open, because that's really a missing component. One of the analogies I bring up when I'm speaking a lot is the front desk syndrome. If you can't get past the front desk, you have no access. It doesn't matter how you got to the building. You could have taken 3 buses, but if you get there and the lady at the front desk is having a day and she doesn't want to let you pass because you don't have this type of insurance or that type of money, there is no access. So for all the wonderful buildings and design, etc., or all of the strategy and this, the underpinnings, if there's no access for that woman or that family, there is no health care. There is no change. And so we've put an open access piece to our program. If you present, you're going to get seen right now, right there. You cannot leave the office without something in your hand, whether it's referral, whether it's an appointment for your first visit, whether it's labs. Something's going to get done for you that day, so when you leave, you feel like you've achieved something, and that therein brings the word of mouth, which all of a sudden, these barriers that we're very concerned about, poof, have disappeared. Women can find a ride, the neighbor will drop them, their girlfriend will take off from work, whatever is needed. If they feel welcomed, they're coming back, and they share within the community very quickly. It's like wildfire. I've never had to market for our outreach program. We don't have outreach workers, we can't afford them. But people come and they'll stay because they feel welcomed. And that is one of the most cost-effective ways that we have figured out to provide the access to care that is so needed in our inner communities, inner city communities.
Also from Dean Melise, what are the best strategies to use in mobilizing immigrant populations in inner cities to advocate for themselves and for policy changes? I just want to mention that for many immigrant groups I've worked with, in the end, they've decided they need to have politicians in office to represent their interests. So groups like Neighbor to Neighbor, they're called different kinds of organizations in different states, have begun to work with immigrant communities to identify individuals who have the interest, talent, and stamina, really, you need a lot of stamina, to go up against often white, powerful politicians who think they're going to have a free ride, but their communities have become more and more diverse. And we've seen some amazing upsets in elections where immigrants who've become citizens over time, but they're representing a community that is in many respects not always consisting of citizens, but immigrants. They've won political office, and they've been able to become a force for change in that way. Obviously, we've got examples in terms of birth. You might want to speak to that. I know that Boston Medical Center, which is our one of our inner city hospitals in Boston, we had traditional birth attendants working with women in the community and becoming the educators and the advocates that then led to advocacy to get more midwives. It wasn't just driven from the top, it was also driven by women in the community. Because as you say, once women have the experience of midwifery, almost universally that's what they would like to choose again, but it's mostly the fact that you can't. And in our state, we have cities like Massachusetts, well, actually one city that has really good access to nurse midwifery. The other cities, they're sizable, but they don't have access to nurse midwifery care because of this statute that needs to change. So even though we've got urban settings, they're not all the same, because the ones that already have large hospitals, already have large nurse midwifery practices, they're okay, and urban immigrant women have access to midwives, but not in places that have 30, 40, 50,000 people in the city. Then the access is less. Even Worcester, which is our second largest city in the state, has lost access to midwives over the last decade because of the various turf battles. So it's a very nuanced situation. But anything anyone wants to say about the issue of how immigrant populations have mobilized? Well, you've already addressed this already, Giovanna.
Well, yeah, I mean, Puerto Ricans are not technically immigrants because they're American citizens, but they're often treated as immigrants in the United States. But one of the things, I don't know a lot about this, you might actually know more, but the Massachusetts Office of Refugees and Immigrants actually has an interesting model, and part of it grew out of our model in Nuestras Raíces in Holyoke, or the sort of model of Puerto Rican migrants to Western Massachusetts, who started sort of recreating the rural, recreating their agricultural experience and cultural heritage from Puerto Rico in the new urban environment by creating community gardens. And so one of the strategies of MORI, the Massachusetts Office of Refugees and Immigrants, is to actually, and they've worked with us with many different refugee and immigrant populations in Massachusetts, to connect people to the land in Massachusetts and to actually get involved in urban agriculture and community gardens to sort of start recreating your connection to this new home through working the land and to producing your own specialty foods. And so our farm, our 30-acre Connecticut Riverside farm, which was donated by the Sisters of Providence, a Catholic nuns group that supports healthcare in the community, actually donated this land, and that farm now has crop diversity and cultural diversity with many different immigrant populations, including the Puerto Rican migrant population. And there's a sense of connection. There's a sense of being, becoming part of this new home, and people start to bond together and start to feel like they can start taking action in the community and feeling like it's their community, and they have rights then, or they feel like they have rights to get more involved civically in the community.
I mean, I'll just say from having worked on Capitol Hill, vote. I mean, it honest to God matters. Speak out, vote. There's this perception that every immigrant in this country is undocumented. That's simply not true. And to the extent that I can't say it enough. Vote, petition your government, talk to your members of Congress, be visible, be outspoken, because you will be paid attention to. And relative to that, we're in this country, we're about to go through a redistricting process. Fill out your census forms. I feel like one of those TV ads, but it actually is very, very true. Like, whether you have representation in your local community and in the national, and federal, in the Congress, is going to be dependent on how many of you, whoever you are there. And so the census really matters, getting visible really matters, and making sure your political leaders actually represent you. It is their job, and you can vote them out if they are not representing you.
I think it goes without saying that you also have to reach out to prominent existing community organizations to help break down stereotypes about immigrants, because the stereotypes in this country are unbelievable, and they do not reflect what immigrants bring to a community, what they offer, how they live their lives. The ignorance on the part of so many Americans is profound here. So making common cause around many of these issues with existing organizations, and usually it's one person meeting another person, having a conversation, and from there a relationship grows, and then communities can combine their resources and work together. Very often you need somebody who is, or an organization who is more politically powerful to make the case that needs to be made, whether it has to do with, pollutants in an area that is disproportionately including low-income persons or immigrants, but they need a voice that will help eliminate the pollution in that community, or will bring a resource into the community that other communities have, and that just is not a situation where resources are not fairly distributed. Jennie, this is a question to you. The international health community have a goal of providing all women with skilled birth attendants. However, the skilled attendants are often in clinic settings far from the mother's village. Mm-hmm. What should the role be for traditional midwives in low-resource countries? They are being increasingly marginalized.
Well, I really have a concern about that because as I've already mentioned, I believe firmly that we can teach women the basic skills, and most every woman that's interested in birth work, once she's interested in it, she's passionately interested in it. She's not just in a passing thing, she's really strongly interested in it. We have various levels of skills, but we have also very important skills that, the basic emergency skills can be taught to just about anybody, and I hate to put it that way because I'm not trying to dumb down the profession. But, handling a hemorrhage, infection, these kinds of things can be taught. So when we have people that are delivering in outreaching areas and they're far from medical help, the best we can do is equip the attendants that they have without judgment with the skills and the resources that they need. End of discussion. What else should we do? Because if we keep putting barriers in the way, we'll never really get to that other side. I know you've all probably heard about the midwives who are being trained to do cesarean sections. This is powerful thinking, because until we are ready to change and stop thinking inside of our boxes, we would never be able to make these fundamental changes for women's health. If maternal mortality continues at the rate that it is, how are we going to be able to just even wake up in the morning? It's so overwhelmingly depressing to hear these maternal mortality figures. And so I say that we start with the most desperate needed areas and work with what we have already in place. And yes, it's not perfect, but it's a start. Then we build the skills of the women in the more centralized areas and keep on bringing in outside help to help them. I'm looking at teaching in a distance program from my school now. I'm talking about in the United States. But there's nothing to stop with this new technology teaching over the internet internationally. I mean, it just blows my mind what you can do with the internet. 10 years ago, you couldn't even dream of getting an email that had a really large file from one end to the other. Now you can literally sit in your living room and get out your tools, your doll, your pelvis, whatever you need, and show how to free a shoulder from under the symphysis pubis. This is not complicated stuff anymore, and we put barriers in front of ourselves because we complicate things so. And I think that really what we need to look at is how can we start with the smallest, the lowliest, the cheapest, most effective methods and empower the people that are already there in the field to do the work that they can do.
I think, unfortunately, this is also an example of the classic turf battle. I'm familiar with a number of projects in Guatemala and in Latin America where birth centers have been set up. Very well-trained midwives have actually established that they're following best practices, they're getting good outcomes, and along comes somebody who's usually in medicine and politically powerful and tries to shut down the practice or do something that, from a public health point of view, is totally cockamamie. And so these advocates come to academics in the United States and ask for their help. It's a political problem in this case when this kind of thing happens. We've got great examples where and we also have technology that's been created, like the Life Wrap. It buys 4 hours when a woman's hemorrhaging so that she can be transported to a hospital if she's in a rural area and she's hemorrhaging postpartum. And that was a simple technology that I believe was created by a midwife. And so if we can bring these simple technologies to women who are caring for other women in rural areas, then it buys us time to transport them to an urban environment where they may need and get specialized care.
I think you're making Valid point, Judy. And I also think that we maybe could start from the other end as far as the training too. If we stay up with the perinatology teams and the obstetrician teams, it's going to be a long road of bringing that level down. Whereas midwives, we all get along. I mean, there are some infighting on various little academic things, but at the end of the day, we all care about the women. And I think midwives, teaching midwives, and being open to sharing on a level that we respect other midwives, whatever their entry level into midwifery and their discipline, how they provide that care has worked for centuries.
The last question is also for you, Jennie.
Okay.
What can we do to, and this is from Dr. Sengane from South Africa, and the affiliation is listed as Passionate Midwife.
Yay.
What can we do to encourage the father's partners, sometimes it's another woman, to accompany the mothers to the antenatal visits? What strategies can we use to encourage fathers, and I might even add others too, because sometimes the significant other isn't just the father, to provide support to the mothers during labor?
Excellent question. I love it. This is something I struggled with in America, more so than anywhere else. But what I have in my clinic is in each exam room I have a couch. And I'm not saying that you need a couch necessarily, but there's a reason why there's a couch there. And that is so that the dad can come in and feel comfortable in the prenatal exam room. If a woman wants the husband or partner to be there with her, we encourage that at every visit. And we make a big fuss about the father. We try to have an equal footing during the time that we have with them, that the mom gets her exam, but while we're listening to the baby's heartbeat, for example, I'll turn the Doppler up real loud. And I'll engage the dad right away. Oh my gosh, listen to that heart. Oh, boy, you did so good. Dad will just, his chest will swell, he'll smile. And there's a bond that's instantly created between the dad and that unborn baby. Mother in turn is, oh, he's interested? Oh my God, who knew? Then she's got a sense of now there's something going on between the two of them, between the family. As we work with the dads through the prenatal course, they begin to open up and share their questions. Most of the dads are just scared out of their minds, totally panic-stricken and trying to put the bravado on that says, oh, no, I got this. They don't have it. They need some support. They need some information and education. And while we're working on that, we give them practical tips for the labor and delivery. I don't expect a dad to know how many centimeters and what color the water should be and what does this mucus look like. He doesn't care. He needs to know, what can I practically do while I'm standing there like an idiot with all these machines going off, trying to look like I have some control in the situation. So we work from a different angle. It's not all about childbirth education. It's not all about learning these signposts. It's about how can you negotiate through this experience. And at the same time, the woman becomes very much more comfortable with, I'm not putting all of this on him because I've got my own stuff to work with. Suddenly they work better as a team. So we never sit and do the full-blown Aspo-Lamar series in the exam room. But they come out of the experience of being involved with the prenatal care, that they are now empowered to be able to be in that delivery room. And it's one of the things that they take away from our training is that they're supposed to be the first person to get their hand on that baby. That's what I'm happy with. As that baby's coming out, Dad, your job is to get that baby skin to skin with its mom, and you get your hand on top of that baby too. There is nothing in this world that beats the feeling of a brand new child that is your child, that you have had a chance to hold and touch yourself. Before it gets cleaned off, wiped off, rushed off to the nursery, you get your hand on that baby. That bond is instant, and I say that bond is irrevocable. It will last a lifetime. So I really appreciate that question because that's where we're falling down. We're not paying enough attention to the men, and I think you can break many cycles, including the cycle of violence, right there.
I think that's a very good point. A couple of quick things here. Somebody asked about the midwifery film. There are copies here. It's called Why Choose a Midwife? A homegrown volunteer effort, but it's definitely a pure advocacy effort. The other question here is about why the evidence-based care movement has not changed the medical model of OB care in this country. And I might add that to the extent the United States model influences other countries are moving away from the midwifery model in very discouraging fashion. But we do have an effort that has been led by Childbirth Connection based in New York City. And if you're interested, go to childbirthconnection.org. They convened a group of incredible stakeholders. About 300 people came together a little over a year ago in Washington, D.C. It was called the Transforming Maternity Care Symposium. and they have since put out a blueprint, Vision 2020. It was the special issue of the Journal of Women's Health last month. There was a huge press conference that Kaiser hosted about 2 months ago. And that effort, which is bringing insurers, obstetricians, midwives, public health folks, administrators, pretty much lawyers, liability folks, everybody who's in this field together to look at how to solve some of the problems we've had. And also, we've got a few things happening in the government. We had the recent NIH consensus conference, which revisited the question of VBAC, vaginal birth after cesarean, and basically said we've got to turn the ship around and offer women the choice of VBAC. Increasingly, a whole city, not just a community, a whole city has made it impossible for a woman to have that choice. Jennie was talking earlier about the ruse some women have to go through now if they've had a previous cesarean section. They have to wait in the parking lot until the head's crowning, and then they go in the hospital, because at that point they can't do a cesarean. That's the extent to which women have to go to avoid unnecessary and unwanted surgery. And hopefully that consensus conference will change the paradigm here. It's one of the reasons we're seeing the rising cesarean rate. It's the repeat cesareans. We have other efforts as well, but I think that evidence-based medicine is actually beginning to have an impact. The turf battles are still there, but if we, for example, win our struggle in Massachusetts, it's because the legislators looked at the data and stopped just listening to, what the Mass Medical Society tells them to do. And I'm hopeful that for a change, we'll see policy based on the evidence, not based on an old boys network or the fact that the Mass Medical Society has been traditionally so powerful in our state. It's true in other states, and I can give you examples where the medical societies actually very last minute changed a bill in a legislature because they knew the person who was in charge. And Missouri had a very, what I would call, what's the word when someone goes against their word? Well, it's a kind of backstabbing. Anyway, there was a great story to be told by the advocates there. And I don't think it's going to happen again because that particular politician has been threatened with a price, which is, maybe lose your office if you keep this up. I think that politicians have to be honest. And when they make arrangements and say they're going to report something out favorably, they're going to pass it to the other side from the House to the Senate, that they do so in reasonable fashion. They don't wait till 5 minutes of midnight when the legislative session ends, and then therefore it's impossible for the other side to vote, and you've sort of fulfilled your letter, your obligation sort of formally, but not really. So those kinds of things, I think, are raising awareness among advocates about all the things that can happen. Double cross is the word. I can tell you stories about advocates who felt they were double-crossed by legislators who had made promises. And this is real politic, and this is what happens, and this is why we have to keep going back again and again. And it's why I have to say that though many of us are disappointed in some of the policies coming out of the Obama administration, I also recognize the incredible obstacles that man has to face in terms of who and what is politically powerful in this country. So there has to be some forgiveness, I think, along the way when we think about the formidable moneyed interests that don't often reflect best practices, good policies when it comes to women's health or even human health. So we do have challenges, and I think the cities are certainly filled with all kinds of problems, but we also have political power in many of our cities, so that we need to harness that and turn it into for the better for everyone altogether. So we have about 10 more minutes left. We're ending at 9. So if anyone has a comment or wants to get up in these last few minutes and say something or address one of the panelists.
Say something, Judy?
Yeah.
Can I just say something about educating the general public? I find that that's something that, I think in our professions and in our work, we think they know, and maybe they don't really know as much as we would really like them to know. I know as far as maternity care goes, so very few women that I come across really know about their choices. They don't really know what that means. They think they cannot change doctors at 36 weeks. They think that they must lay on that bed and be strapped down. They think that they had to have that C-section because the baby was just so big, and they don't know. And it's not easy to get that information and education out there. But I think that we can add, whenever we're doing work or we're doing a presentation or we're out there with the community group, that we keep pointing out to women the choices that they have. Because I've been surprised at how few women are really aware about, especially in maternity health care. That's what I'm talking about specifically. In maternity health care, the options are there. Even though there are few midwives, the midwifery model can be provided by a family practice doctor. It can be provided by a nurse practitioner or a physician assistant. It's not just midwives that do this model. Even obstetricians do the midwifery model. But you have to know who they are. And we have to share when we find them. And we have to educate and support women in learning more about their bodies and their choices.
Very good point. Anybody want to share a last thought or two?
Yes. Do we advocate for that? I personally do. I can speak for myself. One of my goals with my school will be to train internationally so that traditional birth attendants who want to learn more skills will be able to do that however we can get it done. We're totally unfunded, so I have no clue how we're going to get it done. But it's going to get done because they want to know and they want the support. And I feel like somewhat they are just struggling on, doing the best they can with what they can. Where we can help is that there are certain techniques, there are certain things that we can do that don't cost money. Because money seems to be the issue always. Well, we could do X and Y program, but we just don't have it funded right now. While in the meantime, there are still life-saving techniques. So yes, we believe firmly in that. I don't know if any of you are aware of the upcoming film. Christy Turlington, who is a model, she's made a film called No Woman, No Cry. And she filmed regarding maternal mortality. She filmed in Guatemala, Uganda, Bangladesh, and her American piece, she's filmed at our clinic because she wanted to point out that the prenatal care in the clinic has such an impact in America on maternal mortality. Imagine that those things go together in the United States. But I think that there's a relationship between how care is delivered and what is happening for outcomes. So we're looking at all of these different angles for all these different countries. But at the end of the day, the birth attendant is making the difference. So absolutely yes, to say yes to your question, we support the traditional birth attendants. I do.
I think many public health advocates I've spoken with think that that is the solution.
Yes.
Trying to impose the medical model, which is a far more expensive and unsustainable approach, does not make sense. What makes more sense is to train community women to be the parteras, the midwives, the caregivers for other women in the community. And many of the skills that save lives are basic skills. And you know, if you give the tools that women need to deal with hemorrhaging and infection and even to teach them about obstructed labor, I mean, there's a lot of things that people can do. There are, of course, times where you need emergency medical care, and if you're in a rural area, you're not going to have it, which is why the life wrap was a great invention, because it buys you 3 to 4 hours to save a woman's life. I think that there are many areas where we could come up with these kinds of challenges, and one of the things I wanted to close with is a truism that most of us all understand, but that the things that bring good health to ourselves and our communities, and this is especially true in urban areas, it's the air we breathe, the water we drink, the food we eat, and also the level of violence that we have to confront. Ideally, not much. And those are the things that when you ask women in all kinds of surveys, usually violence is the #1 threat to a woman's health. If you ask women in survey after survey, they put violence #1. But after that, if you think about it, if you have clean air, if you have clean water, and if you have decent food supply, and you can keep violence at a minimum, that's the most important contribution you can make to the good health of women in the community. Medical care is important, access to care is important, but in terms of the final impact, it's probably far less significant. We already know that something like 85% of our cancers are likely environmentally induced, and cancer is now increasingly a big killer. We know a lot about the things that are behind many of our chronic and disabling conditions. Some we don't. but a lot of these are environmentally mediated. And it's very easy to blame individuals. Oh, that individual doesn't control his or her diet. It's all the individual's fault. That person smokes. Yes, smoking does contribute. But many other factors are really about the environment not supporting healthy habits. Why do so many young women smoke? And in urban areas, this is a critical issue. In rural areas as well, but it's young women. In fact, in my own state, it's young working class women between 20 and 24 that had the highest rates of smoking in the whole state. And there was evidence our tobacco cessation and prevention program was working. We took excise tax money from the cigarettes people bought, and we plowed it into an educational program. It was working. We had our academics studying this. Well, then the legislature decided, because the economy is bad, it's going to raid that money. It's not going to be used for health promotion and prevention. Instead, it's going to be used to rebuild roads and other things, which are important. But lo and behold, what happens in the ensuing years? The rate of tobacco use goes up, especially among young girls. So these programs are important and they can work. Yes?
My query to Jennie. Millennium Development Goals 5 wants to reduce maternal mortality rate by 75% in 2015.
Yes.
Do you think that is it possible for developing countries to reach the goal?
I think.
And if not, how is it possible to reach the goal by 2000?
It's hard when you have a date on a goal. The Healthy People 2000, the Healthy People 2010. I'm only able to address America because that's where I am and that's where I work. We were blessed in our study. We found that we actually met the 2010 goal, which was to reduce infant mortality. And we were able to do that, and to the disparity piece. But as far as maternal mortality, the way it's rampant in the world, I wouldn't personally feel that it's that achievable by that date. But I feel like we have to start the steps. And so I think one of the most important things, like I've said already, is let's look at how we can utilize what we already have, what's already in place. The traditional birth attendants, women that are willing to work with other women and support other women, the centralized areas where there are hospitals, learning to use the skills and the resources that we already have, and then focus in on that, because without the focus, it'll dissipate. You see, so I really feel strongly that we have to stay on top of using what we have. There are very few skills. There may be 5. I can't number them, but there, maybe 5 possible things that we could work on. Hemorrhage, of course. Infection. We can do some more preventive work with obstetrics if we really focus. Midwives have figured this out. So if midwives can do this, I think all of us can look at it in the obstetric field. So I'm not very comfortable with the goal, the dates of the goal, but I'm 100% behind the goal itself. Absolutely.
Any last comments, Giovanna or Kirsten? We have about 3 minutes.
Thank you. Sticking with us.
Please come up, help yourself to the DVD, the literature. I think some of the participants can hang around for a while and chat with you informally. And thank you all for coming at this late hour.